All right, now let's talk about neuro. And the first thing under neuro we're going to talk about is assessment. As you can see, LOC is number one. LOC will always be number one when we're talking about the neurological system. And we're going to come back to that in just a little bit. Also, we're going to check out the pupils. And it says on your handout that normal pupil size is 2 to 6 millimeters. And I know you remember in school documenting PERRLA. I know you remember that assessment, seeing how well the pupil reacts to light, how fast it's reacting to light, do they look the same, that sort of thing. And then also we have a corneal assessment. Now the corneal assessment is not just something you and I decide we're going to do on 11 to 7 one night when we get bored. Because if you check the cornea too often, could you cause corneal abrasions? Yes. Now, one way they can elicit this response is just with a piece of tissue touching the cornea barely. Or they can use just a puff of air to see if the patient blinks in response to a stimuli. That's what we're trying to do. Now, hand grips, lifts legs, pushing strength of feet. We're checking for strength and equality, but we're also seeing if the patient will follow a command. We're trying to see if the patient will follow a command. Now, vital signs. Vital signs are typically late changes, but one thing you can look at is the pulse pressure. Now, the pulse pressure will widen with increased intracranial pressure, and as you know, the pulse pressure is the difference in the systolic and the diastolic blood pressure. It's the difference in the systolic and the diastolic blood pressure. We want to notice how the patient reacts to pain. And as you know, the normal way we react to pain is to pull away from pain. All right? Now, another thing is this. If you have a patient who's responding to other things, you just leave off the painful stimuli deal, okay? All right, that's a last resort. And you always start with the least painful and progress from there. But the normal response is to pull away from pain. Patients that are neurologically compromised may do nothing with the painful stimulus, or they actually could move towards the painful stimuli. So we're looking for the reaction to the painful stimuli, sometimes called noxious stimuli, as you can see on your handout. We want to notice if the patient complains of a headache. Here's a rule I follow. Anytime you have a head-injured person or any kind of head thing going on, if they start complaining of a headache, just assume that the ICP is going up. It may not be going up, but see, you and I are going to be better off as brand new nurses to assume the worst about situations. Can the patient speak? Well, we hope so, because this shows a high level of brain function. And we're going to look at movement. Absence of movement is the lowest level of response. So, of course, we want some movement. And then you have purposeful versus non-purposeful movements as well. All right? So we want to notice, is the movement purposeful or is it just a reflex? Oculocephalic reflex, also known as the doll's eyes reflex. This assesses brainstem function, underlying brainstem. All right, so what you do, let's read it first. With the eyelids open, quickly turn the head to the right, and the eyes should move to the left. If the eyes remain stationary, the reflex is absent. All right, so let's talk about the doll's eyes for a second. You want doll's eyes. Doll's eyes are a good thing. But here's the deal. We always associate doll's eyes with things like head injuries and lots of bad things. All right, well, let's think about it. If you have been head injured, we hope you have doll's eyes, because that means your brainstem is intact. Now, you only can elicit the doll's eye response in somebody who is out of it. You cannot go up to your friend at break and say, let me see if you've got doll's eyes, and try to move their head back and forth. Because if you do that, what are their eyes going to do? Watch you the whole time, all right? So it won't work in somebody who's alert and conscious. It has to be in somebody that's out of it. Now, I don't know about dolls these days, but I know when I was little, with my dolls, I could turn their head one way and their eyes would look the opposite. That's where it got the name doll's eyes from. All right. So doll's eyes are actually a good thing if you've had a bad head injury. Ice water calorics, also known as the oculovestibular reflex. It also assesses brain stem function, and that's when they irrigate the ear with 50 cc's of cool water, and normally the eyes will move to the irrigated ear and rapidly back to mid-position. All right, so let's pretend you're taking a little nap this afternoon. And you're just lying there so peacefully, and I'm bored, so I get me a syringe of ice water and sneak up to you and stick the syringe in your ear and shoot the water in there. What's the first thing you're probably going to do? Look towards me to see who you're about to beat up, right? Right. You look towards the painful stimuli. That's the normal response, is to look towards the uncomfortable stimuli. Now, you also need to remember this. When people have had things that are cold put into their ears, like eardrops, or maybe it's an ear irrigation, something like that, if the temperature of the water is too cool, it is not uncommon for the patient to say they're dizzy and nauseated and they may vomit. Well, if this person is unconscious, they can't tell you they're getting nauseated. So before you leave the room, be sure and turn the patient on their side in case they vomit so they won't aspirate. That's an important nursing intervention there. The Babinski, also known as the plantar reflex. Now, this is when the lateral aspect of the foot is stroked and the toes should flex or curl up, okay? That's the normal response. And on your handout, as you can see, it's different if you're less than 1 and if you're greater than 1 year of age, all right? And if you're less than 1 year of age, a positive Babinski is okay. It's okay for their toes to fan out. That's what you want to see. But you don't want to see that in the adult. You don't want the toes to do like this in the adult. You want the toes in the adult, or greater than 1, to curl under or flex. That's what's supposed to happen. So get that straight in your mind. And then we have a reflex scale here. And this is just one of many reflex scales. But the thing I want to teach you here is this, how to document reflexes. If I, using this scale, say that my patient has normal reflexes, how would I document that? Okay, I heard somebody say 2 plus. But you've got to remember to say 2 plus over 4. You've got to have a numerator and a denominator. The numerator, the top number, is the number that you get, 2 plus, when you're doing your assessment. And then the bottom number is always the highest number on the scale. Now, why do we do that? Because different nurses use different scales. Well, we really all should be using the same scale if we all work in the same unit. But just to be on the safe side, we've got to document 2 over 4 so the next nurse can see what scale I was using. Now, the next thing we have are diagnostic tests. And the first one, a CT. And a CT can be with or without contrast. And as you know, the contrast is the dye. And if they're using the dye, that's when you have to get the written consent. Take pictures in slices. Well, all that means is this. When somebody's having a CT of an organ, it's going to take pictures of layers of that organ. So there's lots of different pictures for the radiologist to have to interpret. They need to keep their head still. We're talking about a CT of the brain here. Keep their head still, no talking. Usually on the table, they have a Velcro strap that they place over the forehead to immobilize it, just to remind the patient to keep their head still. Now we have an MRI is next, magnetic resonance imaging. Now, which is better, a CT or an MRI? An MRI, because it picks up on pathology earlier. It picks up on pathology earlier. Now, with an MRI, is dye used? Not usually. Not usually. They can, but it doesn't have to be used here. Is radiation used? No, there is no radiation. So sometimes you can get a test question where you have a patient who's worried about the radiation. You can alleviate their anxiety by explaining that radiation is not used during this procedure. But a magnet is used, all right? A magnet is used, and they will be placed in the tube where the patient will have to lie flat. Now, that depends on the hospital where you work. When MRIs first came out, they were a small tube that the patient had to go through. Well, now then they developed a bigger tube, and now they have the open MRI, so where there's no tube at all. So it just really depends on the hospital in which you work. Remove jewelry, no credit cards, no pacemakers. In other words, no metal at all, okay? No metal. Do fillings in the teeth matter? No, fillings in the teeth do not matter because they are not true metal. They're not a true metal. I mean, who would ever get to have an MRI if fillings in the teeth matter? Okay? Now, they will hear a thumping sound. I've heard people describe it different ways. They're going to hear a sound, and you need to explain to the patient that they will hear this sound just to relieve their anxiety. One of the most important things you can do as a nurse is to relieve anxiety about procedures ahead of time. Warn people ahead of time about what's going to be happening. Now, what type of patient can't tolerate this procedure? Claustrophobic. Claustrophobic. Well, if they're closed in a room or in the small MRI tube, and also y'all with a CT scan, you can become claustrophobic as well because you're still going through a tube. And make sure your MRI patient knows that they can talk and hear others while in the tube, okay? Now, the next thing we have, cerebral angiography. And anytime I see the word angiography, I know we've got a test where we are using dye. Dye is being used. It is an x-ray of the cerebral circulation. They go in through the femoral artery. That sounds like another procedure that we talked about, a heart cath. So keep that in the back of your mind. Pre-procedure, we want them to be well hydrated. We want them to void peripheral pulses again, just like with the heart cath, and we want the groin to be prepped. And explain they will have a warmth in the face and a metallic taste. All right? That's when they inject the dye. They get the warmth in the face and the metallic taste. And allergies, ask them if they're allergic to iodine or shellfish. Iodine or shellfish, because the dye is going to be an iodine-based dye. Now, before we move on, let me explain why the patient needs to be well hydrated. And this is a basic nursing concept. Anytime you have a patient who is receiving an iodine-based dye, there's only one way for them to get rid of the dye, through the kidneys. So that's why we want them to be well hydrated so they can excrete the dye through the kidneys. Post-procedure now, bed rest for 12 to 24 hours. Remember the care of the heart cath patient. And an embolus can go lots of different places. So obviously, I'm worried that the patient might develop an embolus. That would be a major complication post-procedure that you and I would need to worry about. Now let me ask you a question. Can an embolus go to my arm? Yes, an embolus can go to my arm and I'm going to have decreased circulation in this extremity, okay? Can an embolus go to my heart? Yes, and then I'm going to have signs and symptoms that I'm having a heart attack. Can an embolus go to my lung? Absolutely, and that's when I'm going to have a sudden onset of shortness of breath and that sort of thing. And an embolus can go to my kidney. If an embolus goes to my kidney, I'm going to have a decreased urinary output and I'm going to have an increased BUN and creatinine. So yes, an embolus can go lots of different places, but this dye is going into the brain. So on your handout it says, we're looking for a change in LOC. Change in LOC, one-sided weakness and paralysis. One-sided weakness and paralysis. And of course you want to be sure and check the motor for any motor and sensory deficits. So before your patient ever even goes for angiography, should you be doing a neuro assessment? Yes, you get your baseline data first so you'll know if there's any changes when they come back. The next test we have is a myelogram. It is an x-ray of the spinal subarachnoid space. Dye is injected and the table is going to tilt around. Now you need to warn the patient ahead of time that the table is going to tilt because that scares them. Now the reason the table is tilting is to move the dye around, to disperse the dye. Now, nursing care with either. When I say either, I mean there are two different kinds of dyes that can be used. One's made of oil and one's made of water. The doctor decides which dye they're going to use. Now, if they use the oil-based dye, then the doctor's going to have to re-aspirate that oil dye back out. However, if they use the water-soluble, then that one will be excreted through the kidneys. Excreted through the kidneys. Other things you need to remember, NPO, light sedatives, and increase the fluids. That's very important. Y'all, that is a basic nursing concept. Anytime you have got a procedure where we're getting into spinal fluid, you always want the patient to increase their fluid intake, because there's always a chance they're going to lose some spinal fluid. And the best way to help them to replace it and help them make more is by encouraging fluids and by making sure it's not leaking out back here as well. Now, with this procedure, like I said, we did get into the spinal fluid. So we punctured through the meninges, the dura, arachnoid, and pia mater, didn't we? Yes, we punctured all the way through. So is there a chance that infection was introduced? Yes, meningitis is what we call that infection. That's one of the things you have to look for. Chills, fever, positive Kernig and Brudinsky, which I've elaborated on down below. Vomiting, nuchal rigidity, that's stiff neck, and photophobia, where light hurts the eyes. Now, y'all, those are basic signs and symptoms for any kind of meningitis in the whole wide world, all right? Now, EEG records electrical activity, and it helps diagnose seizure disorders. It's a screening procedure for coma and an indicator of brain death. Now, a common rule that's used is this: you must have 3 flat EEGs before somebody can be said to be brain dead. Now, there are other criteria too. That's just one of many that they go by. Now, pre-procedure, hold sedatives. What will sedatives do to the electricity in your brain? Decrease it. You don't want to affect the test. Just like we don't want any caffeine, because caffeine's going to speed up the electricity in the brain. But we don't make the patient NPO. Here's one test where they're not NPO, because we don't want the blood sugar to drop, and you know that would definitely affect the electricity in your brain. Now, during the procedure, we're going to get a baseline first with the patient lying quietly. They may be asked to hyperventilate or cough. That's if you have a patient who can cooperate. If you have somebody who's completely unconscious, they may do things like clap their hands in their face really loudly, blow a whistle in their face, lots of different things they can do to see if they can get some type of response. And you know, with the EEG, it's very important that the environment is really quiet too, because the machine can pick up on external stimuli as well. Now, lumbar puncture is the next thing we have. The puncture site is the lumbar subarachnoid space, and the purpose is to obtain spinal fluid, to check for blood, to measure pressures, and to administer drugs intrathecally, which means into the brain and spinal cord. Now, how is the patient positioned and why? Discuss that with your friend. Well, there's a couple of positions we can choose from, all right? One position would just be propped up over the bedside table with their head down, and we still want a lot of arch to the back. That's very important with the lumbar puncture, is to get a lot of arch to the back, because the more arch we get, the vertebrae will separate and the needle will go in more easily, okay? Now, another position that we've seen people in is to lie on their side in the fetal position. Fetal position, on their side, fetal position. That just means chin to the chest and legs pulled up to the chest. And remember, you really need to get somebody to help you hold the patient in this position. Because you could have, if it's a neuro patient, you could have somebody who's confused, but it's going to hurt when they stick them back there, so they might jerk, and we don't want any sudden movements. So get you somebody strong that can hold the patient into this position, all right? That's a safety consideration there. Now, cerebrospinal fluid, CSF, should be clear and colorless. It looks like water. If it looks like anything else, something's wrong. Post-procedure, they need to lie flat for 8 hours and increase fluids. Now, we want them to lie flat because we want a seal to form back here. We want a seal to form. Leaking can occur in some people. And if you have we'll talk about that in just a second. Just hold that thought. What is the most common complication? A headache is the most common complication. Now, the pain of this headache increases when the patient sits up and decreases when they lie down. And how is this headache treated? Well, bed rest, fluids, pain medicines, and blood patch is what I was about to talk about earlier. If you have somebody who is persistently leaking back here, they're going to have a terrible, terrible headache, and they might go ahead and do a blood patch. And that's just when they draw blood from the patient's arm and re-inject it back here where they initially punctured, and they'll have an immediate seal to form. All right? An immediate seal will form, and they won't leak any more spinal fluid after that. Now, another big complication is called a herniation. This is when brain tissue is pulled down through the foramen magnum as a result of a sudden drop in ICP. Now, this is always a concern because when you're doing a lumbar puncture on somebody, just due to the history of their problem, they may already have some increased intracranial pressure. If you've got somebody who's got pressure up here, that pressure wants to escape. So when the doctor punctures back here, he just created an opening through which the pressure can escape. A vacuum forms, and the brain gets sucked down into the foramen magnum. And you know the foramen magnum is the little round bone at the base of your brain that your spinal cord runs through. It's a fatal complication 99% of the time. I've never seen this happen, but I've talked to nurses who work in trauma centers that have, and what they say happens is the ICP will jump up really, really high and then bottom out to zero, and the patient usually stops breathing and their pupils are fixed and dilated and blown at that point. Now, injuries are the next thing we're going to talk about. A small hematoma that develops rapidly may be fatal, while a massive hematoma that develops slowly may allow the patient to adapt. So if you've got to bleed into your head, you want to do so very slowly because you can compensate for that somewhat, can't you? All right? Anytime you have a fast and acute bleed into your head, the number one thing that's going to happen, and I don't care what the cause of the bleed is your ICP is going to go up. That's with a stroke, a head injury, cerebral aneurysm that's blown out, whatever. Okay? Now, an epidural hematoma. This is rupture of the middle meningeal artery. And typically we think of an artery as bleeding fast. So that's what's going to be happening here. Now, let me show you what makes this injury different. They get an injury, such as they get knocked in the side of the head. Usually this person has been in a fight. And they get knocked in the side of the head and then they pass out. But they wake up because they go through a recovery period. But are they still bleeding into their head? Yes, they're bleeding into their head, and finally they max out up here. Their skull can't hold any more blood and their ICP is up. They can't compensate anymore, so they start having neuro changes. They may just start having seizures. Who knows what's going to start happening? They may start posturing. Who knows? But the key is they got knocked out, passed out. They woke up, and then they passed out again having neuro changes, you see. All right. This is an emergency where they're going to have to drill holes, burr holes, remove the clot, control the ICP. So that's why when you have head injured people that come into the ER, you got to ask them questions, such as, did they pass out and stay out? Did they pass out, wake up, and pass out again? Or did they just see stars, all right? Because that'll help identify the type of injury they have and therefore what kind of treatment they may need. Now, a subdural hematoma is usually venous, and normally you and I think of venous bleeds as bleeding slowly. But a subdural hematoma bleed can bleed acute, subacute, or chronic, which just means it can bleed fast, medium, or very slowly. Now, the acute bleed is just like anything else. If you are acutely bleeding into your head, your ICP is going up fast. So they need an immediate craniotomy, remove the clot, control the ICP. Now, the chronic one is the tricky one. This is the one that imitates other conditions, like sometimes they think the patient's drunk. Or who knows, but what could happen is this. You could have somebody who falls down and hits themselves in the head. Well, it's not too bad. They've got a big knot on their head, but they get up and brush themselves off and they're fine. Well, a month goes by and they've been fine, but this morning they walk into the kitchen and they can't use their left arm and they're dragging their left leg and they're talking with slurred speech. Well, what is their family member going to think? Well, they're having a stroke, right? They're having a stroke. So we go to the hospital and they do a history. And they're going to ask about any recent injuries. Well, he fell down a month ago. Is that important? Yeah, because what has he been doing for a month? It says on your handout, he's been bleeding and compensating and bleeding and compensating. But now that he's having neuro changes, he's maxed out. He can't compensate anymore. The volume of the blood in there has gotten to be too much, and he can't compensate anymore. They remove the clot, control the ICP. Now, scalp injury. Well, your scalp is very vascular, and that's when you see people that come into the ER and all of their hair is just blood, okay? And so you rush them back to the back so you can find out where they're bleeding. And when you find the spot, how big is it? This big. Teeny tiny little spot because your scalp is so vascular. Normally what they do in this scenario is they shave around the area maybe and they scrub it out real good, sew it up. And the number one nursey thing you have to do is watch for infection. Watch for infection or teach the signs and symptoms of infection. Skull injury may or may not damage the brain. This is what's going to determine your signs and symptoms. It depends on how hard you were injured or how hard you were hit. An open fracture, the dura's torn. Closed fracture, dura not torn. Now, with basal skull fractures, you see bleeding where? This is what I want you to write down. E-E-N-T. E-E-N-T, which stands for eyes, ears, nose, and throat. Eyes, ears, nose, and throat. Eyes, ears, nose, and throat. Now, Battle's sign is bruising over the mastoid. That's the little bone behind your ear. And with that type of bruising, you may not see that immediately. You may see it 2 or 3 days later. So battle sign is bruising over the mastoid. You may see somebody with raccoon eyes. That's just periorbital bruising. And cerebrospinal rhinorrhea. That's when you're leaking spinal fluid from your nose. From your nose. So they don't need to be blowing their nose a lot. And they don't need to be trying to stick things up their nose to absorb the moisture. We want that to flow freely until it heals by itself. Bloody spinal fluid, and non-depressed skull fractures usually do not require surgery. Depressed do. Well, if you have depressed skull into your brain, that makes sense that they're going to have to go in there and remove it, right? Yes. All right, concussion. A concussion is a temporary loss of neurologic function with complete recovery. They will have a short, maybe just seconds, period of unconsciousness, or they may just get dizzy and see spots. You teach the caregiver to bring the patient back to the ER if any of the following occurs. Now read those things listed there to yourself. Okay? If you have somebody who has injured themselves, maybe they've fallen off the top bunk in the dorm room, all right, and hit their head. Well, and they determine at the ER, hey, we think it's just a concussion. You can go home, but don't go home by yourself because somebody's got to be watching you, right, to see if you start having any of these symptoms because all of these are signs that the ICP is going up. So that means it's not just a concussion, it's something worse, isn't it? Yes. Now, contusion is when the brain is bruised with possible surface hemorrhage. And this patient is unconscious for longer and may have residual damage. So, if you had to pick, would you rather have a concussion or a contusion? A concussion, because you're going to get over that, right? Hey, if you had to pick, would you rather have VFib or asystole? I know, you hope you don't have to pick between those two, right? But if you had to pick, you would pick VFib because at least you're still quivering a little bit. That's a good thing. All right, let's look at the general care for any patient with a possible head injury or increased intracranial pressure. First of all, assume a C-spine injury is present until proven otherwise. Well, how do we prove otherwise? With x-rays. It's the radiologist is going to look at the x-rays, and then they'll call the ER to clear the C-spine, okay? Clear the C-spine. General care for any patient with a possible head injury or increased intracranial pressure. First of all, we're going to assume a C-spine injury is present until proven otherwise. Well, how do we prove otherwise? With x-rays. It's the radiologist is going to look at the x-rays, and then they'll call the ER to clear the C-spine. You never are going to take that C-collar off until the radiologist has cleared the C-spine. Keep body in perfect alignment. Keep slight traction on the head. Once you've started traction on somebody, you do not stop it until the doctor says it's okay. Because if you relieve the traction too soon, muscle spasm can occur, which can cause even more damage. Now, how do we tell CSF from other drainage? Well, it says on your handout that it will be positive for glucose. Positive for glucose. And also there's the halo test. And all that means is this. If you have a bloody spot on the sheet, pillowcase, wherever, if CSF is in that blood, it will settle out and form a ring, a halo around the bloody spot. Now, the next thing on your handout says to ensure adequate nutrition. This is very important for head-injured people because they need increased calories. They're in a hyper-metabolic state, so they need more calories. Now, steroids. Steroids increase breakdown of protein and fat. We learned that the other day, that steroids increase breakdown of protein and fat. Now, why am I talking about that here? Because just about all head-injured people get a lot of steroids because it says over onto the side, steroids decrease cerebral edema, which will make your ICP come down. Makes your ICP come down. All right, so that's why we've got it under nutrition, because it's making you break down protein and fat. Well, it makes sense to me that you can't have NG feedings if you're leaking spinal fluid from your nose, right? Right, because you don't want to get Ensure or something like that around your brain. There's an opening that's allowing CSF to leak out, so it could get around your brain. That's not good. Now, when a patient emerges from a coma, it's not like it is on the soap operas where they've been laid up in a coma for 9 months looking pretty with their earrings on. Now, is it? No. They're going to go through stages. They go through a lethargic stage and then an agitated stage. And in the agitated stage, that's when they want to fight sometimes. And they don't know what they're doing, okay? And the first thing when you have a combative patient is many nurses want to restrain them. Well, that's a big no-no on NCLEX, but it's even a bigger no-no with neuro people because restraints make your ICP go up. Restraints make your ICP go up. They need a quiet environment because any stimuli can promote a seizure. All right, so a quiet environment, pad the side rails in case they do have a seizure. No narcotics. That is a big, big, big no-no with head-injured people because that will mess up your neuro checks. Mess up your neuro checks. Like morphine's a big no-no. Morphine will give you pinpoint pupils. All right? Now, normal ICP is less than or equal to 15. That would be important for you to know if you had a ICP monitor or something that you were looking at, which we're going to talk about in just a second. ICP varies according to position. That's why with head-injured people, we always do what to the head of the bed? Elevate the head of the bed. That's a standard to decrease ICP. Decrease ICP. And as you know, the brain can compensate only to a certain point as the skull is a rigid cavity. That's the adult we're talking about. Now, if you're talking about a baby, it's a different story because a baby has fontanelles. And fontanelles can bulge. Now, you and I never like to see bulging fontanelles. But if you've got a baby with increased intracranial pressure, it's a good thing because at least the pressure has somewhere to go. That is why in the adults sometimes they have to go in and take out a piece of their skull to allow room for the brain to expand. Now, signs and symptoms of increased intracranial pressure. The earliest sign would be a change in LOC. A change in LOC, and we don't care how subtle or minor the change is, we're going to worry about it. The speech may change. It may become slurred. All right? Now, respirations may change. I'm talking about the pattern of respiration here. Well, if the ICP goes up really, really fast, your patient could just stop breathing. But here's the deal. You and I like for people to breathe nice and equal, same depth every time, same number of seconds in between each breath. But if the ICP's going up, the pattern may change. You may have somebody who breathe really shallow, and then they'll have a period of apnea then. All right? And examples of patterns, Shane Stokes. Usually you only see Shane Stokes when someone is dying and we're letting them die, like in someone who's terminally ill, or ataxic respirations can also occur. Increasing drowsiness, these are some other signs of ICP troubles. Subtle changes in mood, quiet to restless, flaccid extremities. The reflexes may become absent altogether. In a profound coma, the pupils will be fixed and dilated. Projectile vomiting can occur because the vomiting center in the brain is being stimulated. Now, here's the deal with that. Anytime you have a head thing and the patient begins to vomit, you have to assume that the ICP is going up. Posturing can occur, and that might be decerebrate or it might be decorticate. Well, whether it's decerebrate or decorticate, all right, is the patient in these positions rigidly or flaccidly? They are rigid. They are tight. They are in an isometric hold 24 hours a day. Why is that important? Because they're burning more calories now. They're burning more calories than they ever have. That's why when people start to posture, the doctor will hurry up and start tube feeding. Hurry up and start tube feeding because they're burning so many calories. All right, and then you may have hemiparesis, which is weakness, hemiplegia, paralysis, or you may see facial paralysis too. Now, let's look at the treatment for increased intracranial pressure. Osmotic diuretics, that's one of the standards of care, and the one you and I are probably most familiar with, mannitol. You may see glycerol used too, but let's look at how these work. They pull fluid from the brain cell. Well, if you're pulling fluid off of the brain, your ICP is going to go down. Well, what's going to happen to the fluid? It says on your handout, it is put in the general circulation. This increases circulating blood volume. Since these drugs increase blood volume, what does this do to the workload on the heart? Increases workload on the heart. And due to the increase in circulating blood volume, does this put the patient at risk for fluid volume deficit or excess? Excess. You've got to be watching your patient for fluid overload. That's why it says on your handout that Lasix is frequently given with these drugs to enhance diuresis. To enhance diuresis. All right. Steroids, well, that's another standard of care, like Decadron, prednisone, IV, to decrease cerebral edema. Decrease cerebral edema. Also, hyperventilation may be used. Now, you know when you hyperventilate, you blow off CO2 acid, don't you? Yes, you're blowing off CO2 acid, so that leaves you a little alkalotic inside, okay? Which is going to make your brain vasoconstrict, which makes your ICP come down. Now, let's think about that. Normally, when you and I think about vasoconstriction peripherally, we think that the blood pressure goes up, and it does peripherally. But here's what I want you to think of here. If your brain is vasoconstricting, it's clamping down. So can as much blood get up here to my brain? No. Less volume, less pressure. Less volume, less pressure is what you have to remember here. So the ICP is coming down. Keep temperature below 100.4 because an increased temp will increase cerebral edema, which will increase ICP. You know, in some head-injured people, their hypothalamus is messed up. So they may have to be put on a cooling blanket to control their body temperature. Avoid restraints, bowel and bladder distension, hip flexion, bowel salva, isometrics, no sneezing, no nose blowing, decreased suctioning and coughing, because all of those things will make your ICP go up. Space your nursing interventions. Anytime you do something to your patient, their ICP is going to go up. That's why you only do a little bit at a time throughout the day to your patient. Now also, you see on your handout where it says spinal cord injury, autonomic dysreflexia is a problem we have to look at, okay? So let's go ahead and talk about this now. Anytime you have somebody with a spinal cord injury, one of the major complications you look for is autonomic dysreflexia, or hyperreflexia it's sometimes called. Well, what is it? Well, it's when all of a sudden your blood pressure goes up, your pulse goes up, your temperature goes up. All your vital signs are up. And usually the cause of this is some type of stimuli, such as a distended bowel or a distended bladder. A distended bowel or a distended bladder. Well, if this should happen to your spinal cord injured patient, the first thing you do is elevate the head of their bed. Elevate the head of their bed. That's the first thing you do to drop the pressure. To drop the pressure. And then you've got to check them to see if they are impacted and therefore they need an enema, or do they need a catheter? Maybe their bladder's distended. All right. Also on your handout it says to watch the ICP monitor with turning, because we know every time we do something to the patient, the ICP is going to go up, but it's supposed to come back down in 15 minutes. If that ICP has not come back down in 15 minutes and you've just turned your patient, obviously they aren't tolerating that side real well. They may put the patient in a coma. We call that a barbiturate-induced coma, all right, to decrease cerebral metabolism, and phenobarb is usually used for that. Also, elevate the head of the bed. We've said that makes your ICP come down. Keep the head in the midline so the jugular veins can drain. If your head is flopped over to one side, the jugular veins can't drain the brain adequately. That's why we want to keep the head in the midline, so we get good drainage. Monitor the Glasgow Coma Scale. It looks at eye-opening, motor response, and verbal performance. It's just a way of putting a number on your coma, all right? And the maximum, the best score, is a 15. We need to restrict fluids in head-injured people to 1,200 to 1,500 cc's per day, because you know if they take in too much fluid, that's going to make their ICP go up. And we don't want that, so really do good I&O on these people. And we need to ensure cerebral tissue perfusion. You've got to watch for bradycardia. Think about that. When your heart rate drops, are you pumping out as much volume as you used to? No. So your cardiac output just dropped, right? Yes. Your cardiac output dropped, so you don't have as much blood going up to your brain. That's not good. Something else you have to watch for is an increased blood pressure, because, again, cardiac output has dropped. Anytime cardiac output has dropped, you're not perfusing the brain adequately. So watch for those two things. And then the last thing we have here would be our ICP monitoring devices, like a ventricular catheter monitor or a subarachnoid screw. The greatest risk with either one of these devices would be infection. Infection. And the way we fight infection is we don't want any loose connections, and we keep the dressings dry, because we all learned in our hand washing checkoff that bacteria can travel through something that is wet much more easily than something that is dry. So we're going to keep all those dressings dry. All right, now, before we close, let me give you a little scenario here. Let's pretend that you've got a patient with Parkinson's. Tell your friend what a patient with Parkinson's looks like. Okay, so we've all got the general picture, don't we? Okay, yes. They've got the slumped posture, shuffling gait, and blank affect, right? Yes. Well, let's pretend on the test they're going to make us buy our Parkinson's patient some new shoes. Now, do you prefer the hot pink furry slippers, or do you prefer the brand new New Balance tennis shoes? Ask your friend. You better have picked the hot pink furry slippers. Now, you'll never find this kind of information in a book. This is how they make it in Clexi. They're always putting you in a bind. See, the first thing that popped into your mind is, oh, you never put slick shoes on somebody. They're going to fall. And then you thought, I don't know of anybody that wants to wear hot pink furry shoes, all right, especially at that age. But you have to pick that as the answer, because if they've got Parkinson's, they've got a shuffling gait. And if you put New Balance tennis shoes on them, they're going to grip the floor and flip, and now they got a head injury and Parkinson's. That's not nice. You're not going to get a license like that. All right? So we're going to pick the hot pink furry shoes. Now, I've got one more scenario for you. Let's pretend you're a home health nurse. Which patient should you go see first? Should you go see the Alzheimer's patient who has fallen yesterday and their confusion increased a little bit? Or should you go see the diabetic who's been out of their medicine for 3 days, type 2 diabetic, that's been out of their medicine for 3 days after having been on a vacation? Ask your friend. Okay, I know what some of you are thinking. Well, he's got Alzheimer's. He's going to be confused. That's not nice. What did I tell you? We always keep people at their highest level of wellness, even if they have Alzheimer's, dementia, or whatever. You don't, especially when they give you something normal. Confusion is normal for Alzheimer's. When they give you something normal like that, worry. That's a red flag. I said Alzheimer's person had fallen and their confusion had increased. So there's your head injury. Okay, I think if you're a type 2 diabetic and you've been out of your medicine for a while, after your vacation, I think you can wait 2 more hours for me to come and see you, right? That's what I'm talking about with NCLEX, y'all. They're going to put you in a bind, make you think about scenarios you had never thought about before, and that's okay. Everybody can pass the first time, but you got to start with knowing your content like we're going through it first, and then we'll keep practicing scenarios like that. All right, enough on neuro.